disclaimers and legal information. To serve our global audience, we offer simultaneous translation during the webinar. Select your language in the translation window. If you are not on ON24, scan the QR code and use the Interprify app with the given token for translation. On the platform, you will also find widgets that will allow you to interact and engage with our speakers and moderator. Please enter your questions in the designated question field. While our experts will strive to address all inquiries during the webinar, time limitations may prevent some from being answered. For any unresolved query, we are here to assist you. In addition, we will occasionally post questions to obtain your opinion on certain topics. Depending on the settings, you may be asked to submit your answer using your mobile device by scanning the QR codes, or you will receive a pop-up questionnaire. If the pop-up window doesn't appear on the screen, you may need to refresh your browser and reload the web page. We value your feedback. During or immediately after the webinar, please take a moment to complete our survey available via the link for the short time post session. Your insights help us enhance our service and content. Last but not least, please be aware that this program is sponsored by and the speakers are presenting on behalf of Eli Lilly and Company. Kindly refrain from taking pictures or discussing this event on social media. Thank you for your attention. We hope you will enjoy the webinar.
Hello, everybody, and welcome to Let's Change Obesity Care Narrative Lilly-sponsored live webinar. I am Dr. Georgios Dimitriadis, an Executive Medical Director with Eli Lilly for Global Medical Affairs, Cardiometabolic Health, and today I'm joined by an esteemed panel of experts who will tell us all about obesity as a chronic disease, the importance of early intervention and proactive care. At this point, I will let the speakers introduce themselves, starting with the lady in our company. Professor McGowan, please introduce yourself to the audience.
Thank you. So my name is Barbara McGowan. I'm a professor of endocrinology and obesity physician based at Guy's and St Thomas's Hospital in London, where I lead the medical obesity service for severe and complex obesity. I'm also the co-chair of the Obesity Management Task Force for the European Association for the Study of Obesity. It's a real pleasure to be here today. Thank you.
Thank you, Professor McGowan. Professor Al-Momani, please introduce yourself to the audience.
Thank you very much, George. Good day, everyone. My name is Hazem Al-Momani. I'm a consultant bariatric surgeon based at the Royal NMC Hospital in Abu Dhabi, the United Arab Emirates. I'm the head of the department of the Weight Management Unit, a multidisciplinary unit managing complex cases of obesity, offering various treatment modalities. I'm also the chair of the Communication Committee for the International Federation for the Surgery of Obesity and a member of the editorial board for Obesity Surgery Journal. It's a pleasure being with you. Looking forward to hearing all your questions.
Thank you very much, Professor Al-Momani. And last but not least, Professor Ebert, please introduce yourself to the audience as well.
Hello, everybody. My name is Thomas Ebert. I'm an endocrinologist and diabetologist from the University of Leipzig in Germany. And in our department, we have a long-standing history focusing on obesity and type 2 diabetes as metabolic diseases. We focus especially on complications of obesity and type 2 diabetes. And I'm personally interested, especially in microvascular complications. And I'm also very much looking forward to this webinar, including your questions.
Thank you very much for that. Our disclosures can be seen on your screen at the moment. I am a full-time employee of Eli Lilly and Company and a shareholder, and you can see the disclosures and conflicts of interest for the rest of the speakers. Presentations will be followed by a Q&A session, and please use the chat function to interact with the speakers. We will not be able to address any questions relating to specific drugs or any unlicensed treatments of obesity. But if you want these questions answered, please get in contact with your local Lilly affiliates. Excellent. Before we move on, I would like us to take a poll. So please vote for obesity. Is obesity a chronic disease? Vote for yes, 1, or 2, no. Is obesity a chronic disease? Vote 1 if that is a yes, and 2 if that of a person living with obesity, I'm sure you all will find very familiar to your clinical practice. Her name is Susan. Susan is 34 years old. She has a BMI of 30 kilograms per meter squared. She struggles with back pain and has struggled with difficulty maintaining weight reduction. She has pre-hypertension, has a normal HbA1c of 5.5% or 37 millimoles per mole, and the remaining biochemistry shows that she has marginally raised lipids profile. Susan is very frustrated and disheartened because she's tried very hard throughout her life to lose weight, unsuccessful, but marginally successful, has always weight regained and is very disheartened with her progress. Speaking of Susan, think of what you do to manage her obesity, and also think of the potential causes for her difficulty maintaining weight reduction. Professor Everett, over to you for the first presentation around obesity pathophysiology and epidemiology. Thank you.
Dear doctors, thank you very much for kind introduction. And I have the privilege to start this webinar with some basic information on epidemiology and pathophysiology of the chronic disease obesity. And I think in this audience, we all agree that obesity is a highly prevalent disease. It's a complex disease, it's a progressive disease, and unfortunately, it's a relapsing chronic disease. Obesity is characterized by excessive body fat. It is defined using the body mass index of about 30 kilograms per square meters or higher. And most importantly, obesity itself can directly impair the health of affected individuals. So if obesity is that highly prevalent, what are the risk factors? What are the causes for this disease state? And as with many chronic disease states, there is no single risk factor. And here in this overview, some biological risk factors, but also some external, some environmental factors that contribute to an increased risk of obesity are shown. Most importantly, several of these risk factors can be addressed by therapy, by our medical therapy. However, and unfortunately, some of them cannot be addressed, including the genetics. And it is clearly very important to understand the relevance of those factors which we cannot really address, which is genetic. And we got some evidence that the genes are really important to determine a person's risk to develop future of obesity within a given environment. And part of these evidence comes from very elegant twin studies back in the 90s of the last century. And using Swedish data on identical twins which were raised together or which were raised separately, because they were separated at birth, have shown us that the genes really determine the obesity risk. Because in this study, it was shown that the body mass index of the identical twins were really highly correlated, irrespective of whether they were raised separately in a separate environment or whether they were raised within the same family. And some other evidence is there so that we can clearly conclude that a significant amount in the difference in body weight between two different people can be attributed to differences in our genes. But what happens now if obesity has already developed? What is the adipose tissue phenotype? And what are the causes for the obesity-related complications? And on the left panel, you see a healthy adipocyte. And when it turns to an obese status, then these adipocytes become hypertrophic. There's an hyperplasia, and you can also see there are some necrotic adipocytes because the vasculature does not grow accordingly. Furthermore, when we increase our adipose tissue depose to a certain threshold, then our adipose tissue also migrates to other body areas, ectopic fat depots, where the adipose tissue will grow. And we call them visceral and ectopic fat depots. And the papers and the data is there that especially these ectopic and visceral fat areas are predictors of the obesity-related complications. And on the right-hand side, you see one of the pathomechanisms. It is producing inflammatory cytokines, not only by the adipocytes themselves, but also from other cells which are in the adipose depots. As you can see from the references shown here below, this knowledge is quite old. So why haven't we successful in weight loss intervention to prevent these progressing obesity pandemic? Why aren't we not successful in weight loss interventions that can successfully lose weight? And here are some basic ideas why after successful weight loss we have problems in keeping those new weight status. The cause for these problems are peripheral signals coming from different organs, such as the intestine, such as the adipose tissue and others, that signals to the brain and signals a state of nutrient deprivation after weight loss intervention. And especially two intestinal hormones, so-called incretins, the GLP-1 and the GIP, have turned out to be very effective modulators for a weight management therapy. So to summarize this, maintaining a weight loss in a chronic state is very challenging because unfortunately our body has developed compensatory mechanisms that favor a weight regain. And with this, I would like to thank you very much for your attention, and I'm looking very much forward to the next presentations and your questions. Thank you.
Thank you, Thomas, for that great presentation. Before our next speaker is ready for their talk, I will take the opportunity to ask Haz a question about stigma and bias. Do individuals living with obesity experience, in your opinion, bias and stigma? And what could be driving this? Is this healthcare professional related, societal? What kind of bias? Why is it? What drives bias and stigma?
Thanks for the question, George. In fact, this is probably one of the main limiting factors in offering the appropriate treatment for individuals living with obesity. Stigmatization and victimization is amongst the factors that these individuals get exposed to. It limits their access to healthcare. The fact that we know that these individuals will probably be spending less time with their healthcare professionals during consultation in comparison to individuals who are, for example, healthy. There are various reasons for that. Amongst it is probably lack of knowledge of the pathophysiology, the root cause of this condition, and the available treatments. Then obviously there are the social factors. There's always the mindset that individuals suffering from obesity are to be blamed for their condition. It's due to the fact that they eat too much. However, with the mounting evidence, we do realize there are layers and layers to this condition. However, our duty as healthcare professionals, our healthcare providers, is to educate the others that you cannot blame people for a disease. There are factors outside their control that lead them to have obesity.
Thank you very much, Haz, for that. So lack of understanding and knowledge on behalf of the society and healthcare professionals drives this. We will have the opportunity to discuss that in more detail. Barbara, over to you for the next presentation, please. Thank you.
So thank you, Georges. So thus far, we've heard Thomas go through the pathophysiology of obesity. And what I'd like to do over the next couple of minutes is take you through the spectrum of health-related complications associated with obesity. But before I do so, I just wanted to remind everybody that obesity is associated with a reduction in life expectancy. So on average, those people with a BMI of 30 to 35 kilogram per meter square will live 2 to 4 years less compared to people without obesity. And indeed, those with a BMI of 40 to 50 will have a life expectancy reduced by 8 to 10 years. So this is really quite significant. Not only this, people with class 3 obesity are also 3 times more likely to experience episodes of major depression in the past year. So we have a significant burden of mental health associated with obesity. But let's talk about these complications. And there are many, at least 200 complications associated with obesity. We can broadly divide them into 3 categories, which I'd like to call the 3 M's. So metabolic, mechanical, and mental health disease. So let's start with the metabolic effects, which of course affect many organs. So starting with the heart, for example, we see cardiovascular disease, coronary artery disease, myocardial infarction, dyslipidemia, hypertension, and diastolic heart failure. In the pancreas, we have type 2 diabetes, as well as pancreatitis. If we move to organs such as the liver, there are, this is associated with fatty liver, also called MASLD now, and then steatohepatitis, also called MASH, which can progress to cirrhosis. These are important metabolic complications. We have gallstones, we have infertility, polycystic ovarian syndrome, chronic kidney disease, the list is quite extensive. If we now focus on the mechanical complications, then we think about osteoarthritis of several of our joints, back pain, and then other complications such as obstructive sleep apnea, which can affect a significant proportion of people living with obesity. And then finally, thinking about psychosocial effects, mental health issues, these are very prevalent in our population, and we see anxiety and mood disorders. We mustn't also forget cancer, and there is a high prevalence of cancer in patients living with obesity. You can see some of these listed here. There are at least 13 types of obesity-related cancer, and the prevalence of all of these is increased in patients with obesity. What we also know is this leads to early death, and we have a value of 5 million people in 2019 as a result of all these complications. Okay, so when we try to quantify this in terms of the risk of complications, what does this risk look like? Well, what we do know is that obesity increases the risk at least 5-fold of type 2 diabetes, of conditions such as sleep apnea. If we look at hypertension, this is increased at least 2-fold. And when we look at heart failure, asthma, osteoarthritis, chronic kidney disease, this risk is increased by at least 1.5 times. And finally, cancers, this can be somewhere between 1.1 and at least 7 times higher. We also have surveys that give us information, and this particular survey called the Resource Service, which is a European service, nearly 2,000 people, very recent 2023, it showed that approximately 75% of people living with obesity has at least one obesity-related complication. And indeed, those with class 3 obesity, that's a BMI of 40 or above, were even more likely to have multiple complications, and usually at least 3. But let's talk again about cancer and the risk of certain cancers. I've listed 6 of these, depicted in this picture. And what we can see here that if we divide the 3 BMIs, so BMI of less than 25, the central red charts with a BMI of overweight, that is 25 to 29, and then those with a BMI of over 30, we can see that the relative risk of getting a cancer is much higher in those with a BMI over 30, and particularly so for cancers such as adenocarcinomas and endometrial cancer. So it's really important to screen for these cancers when we assess patients. So what can we do about obesity and its complications? Can we improve complications by losing weight?
And the answer is yes. But of course, different amounts of weight loss will help different complications. The good news is that even small amounts, 2 to 5%, can improve conditions such as dyslipidemia, hypertension, for example, or hyperglycemia. For some conditions, of course, we need more weight loss. So, for example, if we want to achieve remission of type 2 diabetes in early diabetes, then we're looking at weight loss of about 15%. But somewhere between 5 and 10% will help conditions such as osteoarthritis or sleep apnea or gastroreflux disease. So different conditions will behave in different ways, and for some of them there is a continuum. So something like blood pressure, for example, the more weight loss we get, the better the improvement in blood pressure. But the message is that even small amounts can be beneficial. And with that, I would like to hand over to our next speaker, who's going to talk a little bit about obesity management practices and what we can do to help people live with obesity. Thank you.
Thank you very much, Barbara, for that very eloquent presentation. And while Haz is preparing for his presentation on obesity management, I would like to take the opportunity and ask Thomas one question relating to your presentation on obesity pathophysiology. So you mentioned in your slide deck, which I found very interesting, that the brain is heavily involved in the pathophysiology of obesity. Can you please reiterate the importance and explain why is the brain an important organ in weight regulation?
So that's clearly a very important point. So the brain is, from my perspective, the central organ in the disease obesity, because the brain integrates many peripheral signals coming from, for instance, endocrine hormones from intestine. It also integrates nerval information for the gastric fillings. It integrates olfactory signals, but also optic information. And it modulates the appetite a person with obesity has. So if we are able to address the brain or parts of these peripheral signals to the brain, then we can clearly make a difference in the treatment of patients with obesity.
Thank you very much for that, Thomas. Haz, over to you, and we look forward to your presentation on obesity management. Thank you.
Thank you very much, George. Following on from Thomas and Barbara, where they've talked to us about the pathophysiology of obesity, and then they talked about how does it affect our body, I would like to share with you my perspective about the current management practices, how we deal with patients suffering with obesity in our day-to-day practice, and what is it that we can do to improve that care. What we know for a fact is that obesity is an underdiagnosed and not a prioritized disease. In this questionnaire of nearly 14,000 individuals from 11 countries, around 54% of these patients had reported that they've mentioned obesity to their healthcare professional during their consultation. However, of this 54%, only 36% were given the diagnosis of obesity. And of these 36%, around 21% had a follow-up consultation, which is a reflection of how poorly we are in diagnosing, in managing and following up this condition. And on average, there is a delay of nearly 6 to 9 years between the start of the struggle of individuals with obesity till the commencement of treatment, which means we've got 6 to 9 years of delayed treatment, denied access to therapies that can potentially avoid these individuals developing irreversible conditions like diabetes, dyslipidemia, hypertension, etc., etc. And then what happens to these 21% who got followed up for a consultation? Data from the US of nearly 2.2 million individuals will tell us that less than 4% of these individuals get access to proven, effective and safe pharmacotherapies. And figures from the International Federation for the Surgery of Obesity and the American Society for Metabolic and Bariatric Surgery, according to the IFSO Global Registry, will tell us that less than 2% of these individuals with established obesity get access to surgery, having taken into consideration that the majority of these individuals have got at least one obesity-associated complication. So we've got a condition which is underdiagnosed, we've got a condition which is undertreated, and for those who are eligible, they don't get the adequate treatment they should get access to. And then we can't help but ask why that is. George had alluded to that earlier. There is a poor understanding of obesity, about the causes of obesity. Why is it prevalent in a certain population, in certain individuals in comparison to the other? But also, and which is more importantly, is the stigmatization of these individuals. Around 62% of women and 54% of men living with obesity mentioned that they were exposed to inadequate terminology, attitude, or behavior from healthcare professionals. So what do we have here? We've got people living with a disease that is underdiagnosed, undertreated, and when they go seeking treatment, they get victimized. So most likely, these patients are not going to seek help again. And not only can we victimize and discriminate against these individuals by our words and by our action, the layout of our clinic should be designed in a way to accommodate and welcome these patients and not to make them feel different. The chairs should be wide enough to make them feel comfortable. The toilets should take heavier weights. The gowns should be large enough. Our beds, the doorways should all be designed in a way to not make these individuals feel uncomfortable. Once we've got all of these in place, we're more likely to have a more engaged patient. And for us, as healthcare professional, this is probably one of the first time in history where we've got medical and surgical societies working hand in hand, side to side, in setting out guidelines regarding the management of obesity. We now have got strict criteria, which are very explicit about what treatment should be offered to every grade of obesity, be it grade 1, 2, or 3, whether it's pharmacotherapy, whether it's surgery. We've got now endocrine society, surgical society, cardiac society, talking about obesity being the core of many diseases. And as Barbara said, more than 200 of which, the treatment for which are there. And we need to familiarize ourselves with the available treatment modalities for this condition. And then what about how do we lead the discussion with our patients in the clinic? The 5A model is a model that we use in our daily practice. Start with an open question. Going back to Susan, we can ask Susan, Susan, how would you feel if we talk about your weight? Once Susan engages, doesn't feel victimized, feels comfortable, we go on to assess the extent of her obesity by getting biometrics, by getting blood tests to assess the extent of her disease and what other medical problems has she's developed. And then what do we need to do? We advise Susan, telling her, look, Susan, you've got grade 2 obesity with diabetes. These are the potential complications. The patients would need to be involved in the journey for us to have a successful one. And once we've been able to agree on a plan to move forward with the patient, we define the limitation and assist the patient and sometimes even their family in overcoming these obstacles. And this is where we're able to develop a healthy relationship and a successful journey. Most importantly, to revisit. Unless we adopt the chronic disease model in managing obesity, similar to what we do with thyroid problems, diabetes, hypertension, we will not be able to achieve a sustainable result. Obesity is a chronic disease. It's not a one-off visit. It's a lifelong journey with the patients. And then this is one of my favorite slides of how I run the discussion with the patients about setting the expectations and agreeing on the target of the treatment plan that we commit the patient to. Most patients will be after the first point, which is to lose weight. And this is very important for them because this is how they see themselves in the mirror. This is how they are seen by their partner, by society, by their colleagues at work. However, and more importantly, for the patient and us, for the short and the long term, is to work towards the other targets. If we put it into perspective to Susan, like Susan, your hemoglobin A1C is borderline. We might be able to bring it down to normal level. Despite you not losing weight at the beginning, this is something that will happen later on. We're more likely to have an engaging patient that will come back to their follow-ups, and we're able to develop a successful management plan. So we're aiming to lose the weight, improve the comorbidity, perhaps even push them into remission, assess the results of the treatments that we are offering them, most importantly, increase their life expectancy. Once we've got that in line, once we've got that into perspective, we've got a patient who's a partner in the journey towards treatment for this condition. So to wrap things up, and this is something very important that we need to take from today's talks, is that obesity is a disease, meaning that there are factors outside the patient's control that contributes to the development of this condition. It's a disease that is chronic, it's complex, and it's most likely to come back. As Thomas has clearly highlighted, the biology is working against us. We need to have a plan, which is a long-term plan, to be able to achieve the success that we aim for. Obesity is a disease that is related to nearly 200 plus medical conditions, related to over 30 types of cancer, and is associated with reduced life expectancy. It needs to be taken seriously, similar to how we deal with other chronic illnesses. And it's very important to incorporate the care for these patients in our day-to-day practice, in our day-to-day clinic, to be able to achieve the desire. This brings my talk to an end. It's been really a pleasure talking to you all, and I really look forward to having your questions. Thank you very much.
Thank you, Haz, for that excellent and practical presentation. We have had the pleasure of 3 fantastic presentations on physiology and epidemiology of obesity, obesity complications, and management. Now is the Q&A session. Is your opportunity to interact with our speakers by putting through more questions. We have already received a few, and we are thankful for that, but we would love to receive as many questions as possible, and we will try our best to answer them all. Excellent. Before we start with the Q&A session, I would like us to go through the polling question once more and see what the impact of the great presentations we had has been. So please vote again. Is obesity a chronic disease after having heard the 1 for yes and 2 for no? Is obesity a chronic disease? 1 yes, 2 no. Thank you. Right, we have a few great questions already. We have one from Gabriela, and this one is for any of you, whoever would like to take that one. So Gabriela asks, does the body, brain have a memory for weight? So this question relates to the weight set point theory. So are we bound by biology to return to a predetermined genetically weight, regardless of how much we try? Who would like to take that one?
So there's always the idea of this set point, which might be shifted towards a lower level. However, there's no evidence for this set point that this can be attributed in medical therapy. So I personally think that our brain defends a certain set point in body weight when we successfully lose weight. And with these signals I showed to you, these are parts of these defense for this set point. However, we cannot manage to manipulate the set point so far. And, I'm not aware of any study that modulated this set point successfully.
I would agree with Thomas. It's a theoretical theory. There's nothing to prove it. And
it's an interesting theory. It's an interesting theoretical
There is a
concept.
set point if you got the right epigenetics, environmental, social, and psychological factors in place. Yes, then you're more likely to be prone to develop obesity. Is there any evidence for it? No.
So can we push the set point with our obesity interventions, Barbara? And is the body fighting back?
The body does fight back, as you know. If we continue to lose weight forever without any defense, we die. So that's why we have this very strong inbuilt mechanism that protects us from weight loss. Can we counteract that? Well, of course, we can make lifestyle changes first and foremost to help us with this, including reducing stress in our lives, including sleeping well, and having a healthy diet. But then I think we do now have pharmacotherapies that can help to sort of push that set point back to a healthier level. And of course, if pharmacotherapy is not successful, then we look at bariatric surgery as an intervention to help us. So we do have strategies to help us, manipulate the set point.
Yes.
But yes.
Fantastic. Thank you very much. So picking up from Barbara's question, Thomas, in your experience and your knowledge and your expertise, how long do you think we can treat someone with pharmacotherapy? Do we need to start and stop? Can we treat long-termly? Do we have any evidence? What is the evidence?
Yeah.
We don't want to mention any specific treatments, in general.
Yeah. I would answer this question not maybe limited to pharmacotherapy alone. Can we stop treatment for obesity at all? And I would say definitely no, because I see obesity as a chronic disease state.
Yes.
And when we compare this to other chronic disease states, such as heart failure, such as arterial hypertension, we would never think of stopping the beta blockers or the RAS inhibitors for hypertension if we manage to successfully lower the blood pressure. So I would answer this question clearly with no, we need to continue medical treatment for obesity.
Fantastic. So reinforcing the statement that obesity is a chronic relapsing disease that requires lifelong intervention. Please, Haz, you're nodding.
What I was saying is the recent advancements have changed our perspective about obesity. It's no longer weight. The weight is only one type or one side of the disease that you see. There's more to it. Same as with diabetes, they used to focus a lot on the blood sugar, but now there's more sides to it. If we stop any treatment, if we don't follow up and comply after surgery, the weight is more likely to come back. If it's a lifelong journey, if someone has got hypothyroidism, you give them thyroxine, the thyroid function is normal, you don't stop it. It's normal because of the medication. And I think we need to do the same regardless. And as I said, whether it's medications or surgery, we need a chronic disease model to be able to treat this condition.
Fantastic. Thank you. That's excellent. We have a question from the UK, so it's only fair to ask you, Barbara. So let's assume that you are treating a patient with an incretin-based therapy, and they reach a BMI of 25 kilograms per meter squared. What would you do then? Would you continue the treatment? Would you stop the treatment? Would you adjust the dose? What would you do? Without mentioning any specific treatments, please.
So I guess we've talked about this already in a sense, because if we stop the treatment, the patient is very likely to regain the weight and the complications associated, with whenever they were assessed at the beginning. I think in real practice, we know what the results of the clinical trials tell us, which is if you do stop the medication within a year, you're not quite back to baseline, but let's say sort of 5 to 10%, depending on which incretin you're using. But in real life, I think what we would do is actually maintain them on the lowest dose of a medication that keeps their weight there. And what does that look like? Well, each patient is very different. They know that they're going to get hungry again. They're going to get those hunger signals back. And so we try and do what's individualized and best for each patient.
Excellent. Personalized management. Fantastic. So let's switch it over to surgery. So Haz, can you kindly remind us what the latest IFSO guidelines recommend for metabolic/bariatric surgery?
Yeah. So quite recently, the IFSO, International Federation for the Surgery of Obesity, and the American Society for Metabolic and Bariatric Surgery have updated the guidelines regarding the treatment options for individuals treated with obesity. And what they've done, they've lowered the threshold for bariatric surgery from 35 to 30. And this is for the Western. Obviously, for individuals from Asian descent, it was actually lowered to even to 27.5. So the latest guideline would state that if you've got a BMI over 30 with one obesity-associated complication, you should be considering bariatric surgery. BMI of 35 and above, regardless of the presence of obesity-related complication, to be considered for bariatric surgery. And these guidelines have recently been updated. They've published the evidence, and the evidence is in favor of an earlier intervention instead of delaying treatment till the complications have developed. To avoid them in the first place is probably a better tactic.
Excellent. Thank you very much for that. Now, Barbara, if I may come back to you, and then I've got a question for you, Thomas. So in your clinical practice, what tools do you employ to assess the risk of developing complications, and how do you have any specific targets or for weight? Do you aim for the same weight reduction for any obesity complication? How do you assess that?
So we take, of course, the full clinical history, and we stage all the complications. There are various staging criteria that one can use. But once we know what the complications are, then we decide what do we want to achieve. Do we want to achieve remission of type 2 diabetes? Do we want to get somebody off their CPAP machine? Do we want to improve the blood pressure? And I guess depending on what those complications are, that will determine how much weight loss we need to achieve. But really, I want to move away really from the weight loss in a sense, because that's sort of a secondary outcome. It's really about improving health and trying to agree what it is that we're trying to achieve, which could be improving mobility or improving mental health scores. So really staging the disease will help us to then get to how much weight we need to achieve.
Excellent. Thank you. Going back to the holistic management. Yes, please, Haz.
What staging systems do you use?
What criteria? Yes.
So in my clinic, I used a King's staging obesity criteria, which is an A, B, C, D. So A for airways, B for BMI, C for cardiovascular, D for diabetes, and so on and so forth. And they're stage 0, 1, 2, and 3 for the most severe disease.
Per criteria.
Per criteria, which goes all the way down to sort of kidney, liver, and so on and so forth. There are other staging criteria, such as the Edmonton staging criteria. So some people may choose those criteria, but the principle is very much the same. It's about staging metabolic, mechanical, and mental health disease, and try to destage the disease by whatever intervention, whether it's lifestyle, whether it's pharmacotherapy, or whether it's bariatric surgery.
Thank you very much. So, Thomas, you were very clear in your presentation about the pathophysiology of obesity and obesity being a chronic disease. However, we have a couple of questions in the chat. And it seems some people are not fully convinced so that it is a disease driven by biology. So can you please reiterate what proportion of obesity factors is driven by biology versus other factors for leading to obesity?
Yeah, so it depends.
And then I have a second part for the question, if that's okay.
Very nice. So, of course, it depends a bit on the meta-analysis you look, but usually for the biological factors, it's about 70% covering the risk for obesity, and those exogenous environmental factors, or whatever you call it, it's about 30% of the obesity risk. And maybe it is important to note in this context that, of course, in a patient, several risk factors are present usually. And if I see a patient in front of me, it's, of course, with 100% guarantee that the next patient I see has other risk factors for his or her obesity disease.
Thank you very much. So I have a second part of the same question. There's a question from Sana, and we're thankful for that question. So if we say that obesity is a chronic disease and a disease and a chronic disease, when do we need to start screening? Do we need to start screening early? What symptoms, complications? When do we want to implement screening for obesity?
So in my personal best case scenario, a screening would be a main task in our GP setting in Germany. And we have established several screening guidelines at different ages to ask for type 2 diabetes, hypertension, etc. But unfortunately, we don't have it for obesity so far. I think we could easily integrate those screening strategies also in these so-called checkups in Germany, investigations, and this would be a very nice situation and time to screen for the chronic disease of obesity as a risk factor for these other complications like type 2 diabetes.
Thank you. And what is your opinion? And perhaps we can, Barbara, and
Yeah, I
perhaps
mean,
we can hear from
obviously
Haz
we
about
need to
the same.
start, children are living with obesity. So I think that the answer is we have to start very early.
Yep.
And so there are various programs that we can
Right.
adopt even in school to try and, I guess, detect the disease or screen
Yep.
for the disease
Yep.
and its complications and
Early intervention,
early
proactive care.
intervention. There's no doubt that early intervention is the key to preventing complications. Unfortunately, we're a long way from doing so, but it's absolutely important, like I said, to recognize it as a disease and to treat it, to diagnose it and treat it early.
Haz, do you want to add something
I
to
would, I would echo Barbara.
Mhm.
The recommendation now is to start as young as 5. And as we all know, childhood obesity is a ticking time bomb waiting to explode. The earlier, the better. The younger generation are growing up in an environment where mobility is limited. The abundance of not so great quality food is a problem. You could just click a button and the food will be delivered to your doorstep. So this is, the sooner we intervene, the better. And the age of 5 has been recommended by some of the societies.
Thank you, especially in the context of family history.
Definitely.
It's very, very critical. Excellent. So if you don't mind, Haz, I've got another question for you. So it's about management of obesity. So where would you see pharmacotherapy fit in your therapeutic algorithm, in your surgical service? Where do you think it's best used? Would you like to use it before? And what is your, the way to integrate it?
So this is an interesting area in our practice. The evidence is being built. We don't have solid data or evidence. There's a lot of data being published about the use of pharmacotherapy, regardless of their type, in the post-operative patients and individuals with weight gain recurrence, and the results are very promising. There have been some published papers about using it as early as 6 months after surgery, with the logic of trying to compound the effect of the surgery. So the weight is dropping, let's hit it hard and hit it hard while it's hot to be able to achieve more weight loss. We have not done this. Where I practice, it's out of pocket, it's not covered by insurance. However, there's a big room for it in individuals who've had surgery several years ago and their weight's starting to creep up. It's less riskier than embarking on a revisional surgery with a higher complication rate. And regarding its use in the preoperative period, a couple of papers have been published from our region in the Middle East, and the results are promising, where people are given these medications to try to downgrade either their complications like diabetes, fatty liver, obstructive sleep apnea.
Size of the liver also facilitates reduction.
Exactly,
with
and to
surgery.
make their surgery
Yes.
less. And the results are promising. It's an interesting area. Let's watch this space, see what happens. I rarely use it preoperatively because where I practice, surgery is covered by insurance, medicine is not, but we're using it
In an
a lot.
ideal world, though, yes.
We use it a lot in the post-operative period in individuals who years have had their surgery and the weight starting to creep up.
Excellent. Thomas, is any weight loss good weight loss? What I mean by that is there a preference to a specific weight loss, adipose tissue versus muscle mass?
Yep.
And then why is it important to maintain muscle mass?
That is a really critical point, yeah, and a good question. We need to address especially the adipose tissue depots, and we need to decrease the fat mass. While in contrast, we need to have the muscle mass at a stable level. Of course, whenever we lose weight, irrespective by which method, there's a certain amount of muscle mass which is also being lost. And this is especially problematic because after a successful weight loss, our energy expenditure is also reduced. And we use and we need physical exercise to increase this energy expenditure after a successful weight loss to prevent a weight regain. So therefore, it is absolutely important what fraction of body composition we are losing. And in our department, we of course have the privilege to have a body composition analysis for every patient to validate that we are doing the right thing to our patients with obesity.
Excellent. So you do body composition in your service. That's amazing.
In a longitudinal way.
Excellent. That's great. That's great. So maybe I can follow up from that question with you, Barbara. So we heard about preservation of muscle mass, but is muscle mass loss important when there is no change in functional status? So, or do we have to take into account both when we are assessing muscle mass loss?
I think we absolutely have to take into account both, and we absolutely want to preserve lean muscle mass. It's important for overall well-being, it's important for energy expenditure, it's important for physical function. So as Thomas mentioned, we want to limit the loss of lean mass, and whilst we want to maximize the fat mass loss, but it is an important consideration when we intervene with weight loss.
Thank you.
Barbara, is that something of significance in clinical practice? Because I know a lot of hype has been raised recently about sarcopenia, and because we've never had this in the past with the surgery, but now with the effective pharmacotherapy, it's making a lot of noise.
I think it's making a lot of noise because suddenly we do have medication that's very effective, first of all, and whereas before we were looking at 7 to 8% or single-digit weight loss, now we're looking at weight loss which is 20, 25%, sometimes even 30%, very similar to bariatric surgery. And that's why it's really important to preserve lean muscle mass, and we do worry about that. I think the good news, at least from what I've seen thus far from the studies, is that there seems to be at least a 2.5 to 3 times greater loss of fat mass to lean mass with the pharmacotherapy. So there's a relative improvement in
the ratio
in body composition, which is good news. But it's very important. I think even after bariatric surgery, it's really important to tell patients to be physically active because especially in the elderly, if we're considering these agents or surgery in the elderly, then of course sarcopenia is an issue, and loss of physical muscle mass is a real problem.
Thank you. That's great. We have a question from Greece. How about exercise after surgery or pharmacotherapy, lifestyle interventions? Is it important? Do you prescribe exercise? Do you refer to an exercise physiologist? Do you tailor the exercise requirements per individual based on their needs?
So, I mean, following on from Barbara, and on one of the slides, physical activity, healthy lifestyle is the core of any treatment modality we offer to these patients. I appreciate it's easier said than done, but it's very, very important. We need to raise our body basal metabolic rate. We need to try in a way to guide the body to lose the weight from the fat, not the muscle. With the surgery, there was a journey. They need to meet certain criteria before they go into surgery. With the new medications, it's sort of a quicker path to the treatment, but with an effect that is very similar to the surgery. Yes, it's very important. A diet rich in food is very important. Ideally, if the luxury is there, to refer everyone to see perhaps someone who could give them appropriate training programs. It's very important. Some of them get outsourced to do that, and we do that sometimes.
Great.
It is the core of any successful, durable treatment for obesity.
Maintenance as well, very important. Thank you very much, Haz. That's excellent. So we have another question from Italy, and our colleagues from Italy are asking whether the quality of foods and ultra-processed foods facilitate the emergence of the obesity phenotype relating to epigenetics. Who would like to take that one? Thomas, Barbara?
I think the Italians are playing the Italian card because they know their food is good.
No, they don't suffer with ultra-processed foods that much.
Thomas, do you want to have a go at this?
No, you can go. So in my opinion, of course, these are very important factors and risk factors contributing to an increased obesity prevalence. So we need to consider food not only as food, but consider its quality.
Of course.
Especially the ultra
What the
processed
food does to the body rather than the calories.
Yeah.
It's not calories in that much. It's what the food does to the body, how it interrupts the mechanisms. Yes.
Absolutely.
Please.
I mean, I think a lot of the people that I see living with obesity, for example, they're actually macronutrient in excess, but actually micronutrient deficient.
And I was going to ask you both about
and that's because of the poor diet.
Yes.
But the other thing to say about the ultra-processed food, it's quite addictive, as you know. It sort of stimulates those areas, those hedonic
very
areas.
palatable, yes.
It's very palatable. They put, you know, content in there,
calorically
ingredients in there,
dense,
which
yes.
are addictive. So we absolutely have to work with industry, of course, to make changes to the food that we eat. So this is not, like I said, it's not a single solution here. We have it's a multifaceted solution, which does include obviously targeting this very big problem, I think.
Thank you. Has, you want to add?
I wanted to add is, like, there are some observational studies of Chinese populations immigrating to the US, and they looked at the prevalence of obesity in the second or third generation, despite them having the same gene pool. The prevalence of obesity is higher, and it's definitely
Of course.
the diet.
Yeah, the disease of obesity hasn't changed. It is the environment we live into
We have to
promoting the
we have
obesity
to give it
phenotype.
to the Italian for having a very healthy diet.
Thank you for that question to our colleagues from Italy. Now, we mentioned the micronutrient deficient status. I'm going to ask Haz, if that's okay. So what are your micronutrient trace element supplement considerations following metabolic surgery? And then maybe I can ask Barbara and Thomas the same for pharmacotherapy if they've got an opinion.
So I'd follow on with what Barbara said. Even though their BMI is high, but their reserves are diminished. And we've had a lot of patients where within 2-3 months after their surgery, they start developing neurological complications, peripheral neuropathy, burning foot syndrome because of deficiency of micronutrients. All these patients should be screened preoperatively, ideally, and all of these patients would need to be followed up regularly to be given multivitamin supplements. Nowadays, there are commercially available brands tailored for example, a sleeve gastrectomy, a duodenal switch, or a gastric bypass. In the first year, we tend to do blood tests at month 3, 6, 9, and 12. Then for the second year, we do it at 18 months, 24 months, and then at least once every year afterwards. And every now and then, we do get patients who slip through the net and come to see you in a wheelchair. I've recently had a girl, she's only 18, and she came in a wheelchair feeling numb from the waist down because of vitamin B1 deficiency. And it was literally 2 months after her surgery. So this is our protocol, this is our recommendation.
Thank you very much, that's excellent. Barbara, with surgery, we modify, we adjust the upper gastrointestinal tract, so there is changes in physiology. With pharmacotherapy, we have significant weight loss. Should we have any considerations? Is there any evidence, any guidance? Should there be any guidance, any evidence? Do we need to investigate this?
I think there's probably less evidence and guidance at this point in time because these more powerful medications, or the incretins, are relatively new. Having said that, what we do know that they're very powerful and they do switch off appetite. And some people will say, actually, I've forgotten to eat because I'm not hungry. So it's really important to emphasize that when they do eat, they need to eat significant protein and good vegetables, it's sort of a well-rounded diet. And so, yes, there is a risk that they may be deficient in certain nutrients. Do we need to screen? I think if they're presenting with fatigue or hair loss, for example, we should check iron levels like we do for, for anyone that may present with those symptoms. So we need to have that.
So more reactively because of the lack of evidence rather than proactively.
I think most people that I see actually feel great. They feel healthy. They have a lot more energy. So one would assume.
Happy.
I have to say, sometimes I do say to my patients to take a multivitamin A to Z.
It is sensible.
Because it's a pragmatic approach, and then I know that that they should be fine. So that's my approach to, if they're losing 20-25% of weight loss.
Thank you. That's great. Thomas, do you have anything to add on that point?
I fully agree. We use exactly the same routine for our patients undergoing bariatrics or metabolic surgery, and we also screen at baseline for our patients on medical therapy and a lifestyle intervention program. But we do not supply any additional micronutrients as a standard therapy.
Thank you very much. So Haza, I've got a question for you. And this is a question, a topic we didn't touch on at all. So the question is around endoscopic interventions or obesity management. And without mentioning very specific details, because some of these may not be available or licensed in some of the countries, do you think there is a role for endoscopic interventions as part of the holistic management of obesity?
So endobariatrics is an evolving field in the treatments available for obesity. We've got some established treatments with established safety profile and efficacy. They're not as effective as surgery, however, there is room for them. And to prove what I'm saying, watch this space. Perhaps towards the end of the year, beginning of next year, if so, we'll be issuing their position statement regarding endobariatrics. So in short, yes, they are there. They are here to stay. It is important to have them as a treatment modality available for individuals suffering with obesity. There is room for them in selected groups of individuals in the hands of well-trained and experienced endoscopists.
Fantastic, thank you. Barbara, do you have an opinion on the matter from a medical point of view on the role of endoscopic treatments?
I think it's part of the armamentarium that can be offered. And so I think they do have a role to play. I completely agree in the hands of expert endoscopists that know what they're doing and know how to assess patients living with obesity.
Thank you. So I think we have time for one more question. So there is a comment about psychological therapy and how this can be part of obesity management and whether it can modulate satiety. So is psychological management important when assessing and treating a patient with obesity? Maybe you would like to take that one, Thomas?
Absolutely. It's standard to screen for psychological comorbidities or complications of obesity, as we heard. Many patients are affected by psychological complications, but it's also directly inducing, potentially, the obesity. So we screen at the first initial visit for psychological comorbidities, for psychological factors contributing to an increased obesity risk. So we need to keep this in mind, and we need to screen all of our patients at the entry of or at the beginning of our therapy.
Excellent, thank you. Well, I believe we answered most of the questions, and thank you very much for putting these through. There are 3 takeaway messages I would like us to take from this session. The first is that obesity is a chronic, relapsing disease requiring lifelong treatment and management. It requires early intervention and proactive care. With that, I think the only thing remaining for me to do is to thank you, the audience, for joining this webinar, and to thank our fantastic faculty for their excellent talks. I hope you all enjoyed it, and you have a fantastic remaining evening, and thank you very much indeed.
Thank you.
Thank you.
Thank you.